Postpartum hemorrhage. Postpartum hemorrhage is defined as excessive blood loss, that is more than or equal to 500 ml in vaginal delivery or more than or equal to 1000 ml in C-section immediately after delivery or until 12 weeks after delivery. So according to American College of Obstetrics and Gynecology, latest definition says that irrespective of the route of delivery, if the blood loss is equal to or more than or equal to 1000 ml, then it is considered as postpartum hemorrhage. Clinically, we can assess by we can say a patient is going into postpartum hemorrhage if there is any blood loss which is leading to signs of hypovolemic shocks. That is, the patient is having increased pulse rate and decreased BP. So practically we can assess by a drop in hematocrit more than or equal to 10%. Now coming to types of postpartum hemorrhage, there are two types of postpartum hemorrhage. That is primary postpartum hemorrhage, which occurs within 24 hours of delivery, and most common cause is atonic uterus. Second is secondary postpartum hemorrhage. It is postpartum hemorrhage occurring after 24 hours of delivery but within 12 weeks of delivery. So most common cause here is due to retained placental tissue. Now coming to causes of postpartum hemorrhage, it is by 4 T's. That is tone, trauma, tissue and thrombin. So first cause is decreased tone of the uterus, which is the most common cause. Second is trauma in the form of cervical tear, which is most common, vaginal hematoma and uterine rupture. Third is retained placental tissue. And fourth is decrease in thrombin, that is bleeding disorder. Coming to risk factors of postpartum hemorrhage, maternal factors are multiparity, anemia or malnourishment, antepartum hemorrhage in present pregnancy, PIH in present pregnancy, previous history of PPH, overdistended uterus, that is in twins, or diabetes or polyhydramnios, and fibroid uterus. Coming to labor-related risk factors, it can be precipitated labor, that is labor lasting more than 3 hours, prolonged labor, instrumental delivery, C-section, or injudicious use of oxytocin or sedatives. Coming to placental factors, it can be retained placenta, placenta previa, placenta accreta, and placenta succinturata. So we can assess the patient according to shock index. So shock index, how we assess is heart rate by SBP, that is heart rate by systolic blood pressure. So normal shock index should be between 0.5 to 0.7. But normal shock index during pregnancy is 0.6 to 0.8. So when do we say that the patient is landing in shock is if the shock index is more than or equal to 0.9 to 1. So this is an important indication for blood loss. Blood transfusion. Now blood transfusion may lead to disseminated intravascular coagulopathy. So it's always given with the fresh frozen plasma. Fresh frozen plasma is always given with blood transfusion. Now coming to management of postpartum hemorrhage, the first step that we can do is uterine massage plus non-specific measures and specific measures, which I'll be telling. And second step that we do is further management depending on the type of PPG. Depending if it is due to any trauma, then according to trauma we have to treat. If it is due to atonic or it is due to bleeding disorder, so according to the cause we can further manage. Now coming to the non-specific measures that we can do is, first is we have to immediately put the patient onto large bore IV cannulas on either hand and start the patient immediately on RL or NS. We shouldn't give 5% dextrose here. And immediately when we are putting the IV cannulas, we should take the blood and send the patient for assessment of blood group and RH typing and CBC for arranging of blood transfusion. And we have to also arrange at the same time blood and fresh frozen plasma, and patient should be catheterized as soon as possible. Now coming to the specific measures for control of bleeding that we give is injection tranexamic acid. So we do is we start tranexamic acid it should be started within 3 hours of postpartum hemorrhage. So the dose that we give is 1 gram in 10 ml of NS slow IV. So why we are initially when I told that we are doing uterine massage, so uterine massage we are doing because massaging the uterus helps in contracting the uterus. So this helps in diagnosing the cause of PPH, because in atonic uterus will not be palpable per abdomen. In traumatic PPH, uterus will be palpable per abdomen, and in retained placental tissues, intermittent contraction and relaxation of the uterus. So this can also help in diagnosing the cause of PPH. Now, after we have given injection tranexamic acid, further we can manage the patient by uteronic drugs. That is, we have to give uteronic drugs within 30 minutes. Then mechanical compression we have to do. If even after this, all these measures, if it fails, then we have to do surgery. So depending if the patient is stable or unstable, if the patient is stable, we'll do uterine artery embolization, which is blocking the vessel via femoral artery, or apply compression sutures surgically. So if the patient is unstable, then devascularization surgery should be done. That is ligation of the artery here. So if in stable patient, when we have done uterine artery embolization, if that also fails, then we give devascularization surgery. Now, devascularization surgery, what we do is we bilateral uterine artery ligation we do, and if that also fails, if the patient is stable, then we will ligate the anterior division of the interior iliac artery, and if the patient is unstable, then we will do hysterectomy. So most commonly that what we do is subtotal hysterectomy. Now, coming to the uteronic drugs that we are giving, our first is oxytocin. So we give 20 international units of oxytocin, and it should never be given in bolus, and it is a first line drug recommended by WHO for prevention of postpartum hemorrhage. Second line drug that we give is methyl ergometrin. So 0.2 milligram IM we should give, and it should be repeated every 20 to 30 minutes, and maximum we can give 5 doses. This also should never be, methyl ergometrin should never be given IV because it can cause hypertension. Third is carboprost or dinoprost, that is PGF2 alphas. So here we give is 250 microgram intramuscular we give, and we repeat it again at 15 to 90 minutes, and maximum dose we can give is 8 dose. And we should remember that carboprost and dinoprost are contraindicated in asthmatics. And we can give add-on drug of misoprost also, 800 microgram sublingually. So, but it is contraindicated if the patient has a previous C-section. Coming to mechanical compression of uterus, so it can be done by SB esophageal catheter or Bakri balloon catheter or condom catheter. So the purpose of mechanical compression is we fill the bulb with normal saline and inflate it. Now this presses against the open venous sinuses and prevents blood loss. So maximum capacity of Bakri balloon catheter is 500 ml. Coming to compression sutures, we can do B-length sutures, which are the most common. Then we have Heyman, Ganshala and CHO square sutures. And devascularization surgery, we do if after mechanical compression also patient's vitals are stable. If compression sutures fail to control bleeding in a patient whose vitals were unstable. So most common artery ligated here is uterine artery, and subtotal hysterectomy we can do it's the last last method of treatment. The advantage is that it is quicker procedure to perform, and the entire cervix and vagina are intact. Only uterus is removed and not the cervix. So that's all.